Hi, my name's Oscar. I'm a student at ECU. I work at SAS, the South Australian Ambulance Service, and this is my video for shoulder dystocia. Basically, during the video, we'll go through all the maneuvers to try and alleviate shoulder dystocia. Before starting though, we'll obviously be wearing PPE, so eye protection, a mask, gown and gloves for droplet precautions. Some indications for or risk factors for shoulder dystocia include basically large babies, so babies born to diabetic or gestational diabetes, mothers with gestational diabetes, males, induced labor and instrumental births. The last two don't really apply to pre-hospital, so for us it's just basically patients born to diabetic mothers would be a risk factor and would be anticipating a large baby in that case and likely to get stuck. Usually it's the anterior shoulder that gets stuck behind the pubis symphysis. On occasions it's the posterior shoulder that gets stuck though too. Most of the time it is the anterior shoulder, and most maneuvers are there to alleviate or dislodge the anterior shoulder. Some complications, the big ones would be for the fetus, fetal hypoxia. That would be due to clamping of the cord or basically stopping the blood supply flowing through the cord, or inadequate respirations if the baby is already breathing spontaneously. Fractures from mainly clavicle fractures. These can be done purposefully as well if a practitioner breaks the clavicle in a last-ditch attempt to get the baby out. Brachial plexus injuries. So during the maneuvers, you'll have a lot of times where you do sort of a diagnostic sort of axial traction to try and help deliver the baby. That's putting very, very lightly in line with the spine. At no point do you want to move the baby's head left, right, up or down. Sort of bending you could cause, like I said, brachial plexus injuries, and those would be quite devastating. On the mother's side, tearing is a big problem, so perianal tearing and postpartum hemorrhage. Those are pretty much the big risk complications of shoulder dystocia. Alright, so first things first, we'll have started the delivery. We've obviously identified second stage labor. The baby's head is born. We then notice that the baby's not coming out. There's the turtle sign at times where the baby basically retracts back into the perineal tissue, basically up to its chin, and whenever the mum pushes, it comes out a little bit and then it retracts again. That's called the turtle sign, so that indicates that we probably have shoulder dystocia. Difficulty delivering the head and face is another sort of thing. All the maneuvers we do for 30 seconds. And after 30 seconds we move to a different maneuver, so we don't waste too much time trying to basically deliver the baby on one maneuver that's not working. So the first maneuver you'll do, once identified, we'll do the Mac Roberts position. So we'll usually need a couple of extra practitioners to do this. And the way it's done is we lift mom's knee to nipple, flexing the thigh, abducting the thigh, so the legs will come out to the side and right up. This sort of opens the diameter of the pelvis and hopefully will dislodge posterior or anterior shoulder. In this position, obviously every time the mother has a contraction, we ask her to push, we give a little bit of axial traction, and we hopefully deliver the baby. If this doesn't work after 30 seconds, we'll move on to suprapubic pressure. The first sort of maneuver we do is in a CPR type of grip. We locate the pubis symphysis. Just above that or just under that, you could say is the anterior shoulder that's probably lodged. We try and feel if we can feel it. If we don't, either way, we'll apply 30 seconds of a constant sort of pressure while mom's pushing on contractions, and another practitioner will be trying to deliver the baby. Just back to the Mac Roberts position, we'll need a lot of practitioners to hold the legs up and keep them in that position, because a tired mom that's gone through a long sort of labor now might be too tired to keep her legs in that position. But anyway, so yeah, 30 seconds of suprapubic pressure. If that doesn't work, we move on to what they call the Rock and Reuben maneuver, which is the same sort of thing, pushing on the anterior shoulder in the direction of the child's face, and we do a pulsating sort of motion like this, 30 seconds. Hopefully the mother will be able to push the baby out on the contractions, or whoever's delivering the baby will be able to assist her get it out. Yeah, if that maneuver doesn't work either, we'll move on to turning the mother onto all fours. Basically the reverse Mac Roberts position. The way she does that is she just basically gets into all fours, hips up as high as she can, head down as low as she can. Just getting into that position often dislodges or disimpacts the shoulders, and the baby and gravity will sort of help deliver the baby. we'll try and deliver the baby for 30 seconds in that position. Once again, if it's not successful, hopefully we've called for help. Another big thing in the pre-hospital field is phoning for help, so getting a retrieval team out, like a response team with a doctor on it, or either getting the mother ready for rapid transportation to an appropriate hospital en route, IV access, oxygen, supplemental oxygen to in case the baby's hypoxic, and basically carrying on with trying to deliver the baby. However, if we're too far from a hospital or there's no way we can do that, with the mother's permission we'll move on to internal maneuvers. Turning her back onto her back. The first internal maneuver is the room 2 maneuver. Basically what we do, so like I said, mother's consent, 2 fingers of the paramedic hand on the anterior shoulder on the posterior side, and then pushing the shoulder in the direction the baby's facing to sort of adduct the shoulders, decreasing the diameter of the shoulders, and hopefully getting that shoulder out under the pubis symphysis and delivering the baby. We'll try that for 30 seconds. If that doesn't work, we'll keep our hands in that position. Then the paramedic will insert another 2 fingers on the posterior shoulder, on the anterior side this time though, and then we'll try and turn the baby. So this is the Woods corkscrew maneuver. The idea here is to turn the baby into another plane, so basically disimpacting the anterior shoulder or the posterior shoulder and delivering in a different plane essentially. If that doesn't work, what we do is we drop the first hand down onto the back of the posterior shoulder. We take the second hand up, we put that on the anterior side of the anterior shoulder, and we do the reverse wood screw maneuver, which is turning the baby in the other direction. Once again, 30 seconds for each of these maneuvers. Hopefully the baby will sort of dislodge and be born. If not, we will try and remove the posterior arm. This is done by introducing 2 fingers, finding the posterior arm, flexing at the elbow, and then basically sweeping the arm across the face. Once that arm is delivered, hopefully the baby drops down, and we can deliver the baby because the anterior shoulder is dislodged. Alright, so hopefully one of these maneuvers will get the kid out. Once the baby is born, it's normal sort of postpartum care. So basically we'll stimulate the newborn, we'll dry the newborn will go straight to the nipple if the mother is happy with that. We'll clamp the cord once it stops pulsating, we'll cut the cord, then we'll have 2 patients. So we'll do standard sort of supportive care for the mother and supportive care for the newborn. One of the big complications on the mother's side is postpartum hemorrhage. So what we'll just make sure is we'll inspect for any tearing, we'll apply direct pressure to those. If the bleeding is from internally, we'll make sure that there's good tone on the uterine or the uterus, so we'll sort of massage that down, do a nice fundal massage, and hopefully that will contract and stop any bleeding. Also we'll have our IV access in, and basically then we'll just head off to the hospital, and hopefully that's that. Alright, thank you.